All right, let's jump right in. Today, we're tackling a condition that you are absolutely going to see all the time in your clinical practice, irritable bowel syndrome, or IBS. For our patients, it can be incredibly frustrating. And for us, well, it demands a really thoughtful, systematic approach. So today, we're going to build that framework together.
So here's our game plan. We're going to walk through IBS just like a real clinical encounter. We'll start with a patient's story, then nail down the diagnosis. From there, we'll figure out how to subtype it, which is key for treatment. Then we'll get into the management plans for both the constipation and diarrhea types, and finally, we'll zoom out to see the bigger picture.
Okay, first things first. Before we get into any criteria or medications, let's ground this whole discussion where it actually matters, with the patient. Understanding their experience is really step one.
Man, that quote really says it all, doesn't it? This isn't just about tummy troubles. It's about the constant disruption, the unpredictability, and that deep desire just to have a normal day. That is the core problem that we're being asked to help solve.
Okay, so with that patient's voice in our heads, our first job is to move from this cluster of symptoms to a solid, guideline-based diagnosis.
So this is the big question, right? How do we take this, kind of vague story of GI distress and apply a structured framework to it? It's all about being systematic, so we can confidently say, yes, this is IBS. And just as importantly, no, it's not something else.
And our foundation, our absolute bedrock for diagnosis is the Rome-4 criteria. Don't just think of this as a checklist. It's a powerful tool that anchors the diagnosis to the most important feature, that recurring abdominal pain, and directly links it to a change in bowel habits. This is how you make a positive diagnosis of IBS.
But hang on. Before we stamp IBS on that chart, we have to pump the brakes and actively screen for these alarm features, these red flags. Any one of these should make you pause and think about other more serious possibilities. Seeing these means it's time to dig a little deeper.
So this lays out a really smart and efficient workup. You start with a great history and physical, you apply those Rome IV criteria, and then you use just a few high-yield tests like a CBC and a fecal calprotectin. And notice, a colonoscopy is not automatic. It's really reserved for patients over 45 or for those who have one of the red flags we just talked about.
All right, we've confidently diagnosed IBS. Now we hit a major fork in the road, a decision that's going to guide our entire treatment strategy. We have to subtype it. Is it constipation predominant, diarrhea predominant, or a mix of both?
And the tool for the job might seem a little simple, but it is incredibly powerful. It's the Bristol Stool Form Scale. This gives us a common language. It takes what can be a really subjective description from a patient and turns it into an objective measure, classifying everything from type 1 hard lumps to type 7 liquid.
And once you use that scale, the subtyping becomes pretty straightforward. If more than a quarter of their bowel movements are those hard, lumpy types, so type 1 or 2, we call it IBS-C. On the flip side, if more than a quarter are the loose, watery kind, type 6 or 7, then it's IBS-D. Simple as that. And then, of course, there's the tricky one, IBS-M, where M is for mixed. These are the patients who are stuck in this frustrating cycle of both extremes. They actually meet the criteria for both constipation and diarrhea, and that presents a really unique challenge for us.
Okay, diagnosis, check. Subtype, check. Now we can finally get to what the patient really wants to know, how we're going to treat it. Let's kick things off with our playbook for IBS-C.
So for IBS-C, what are we actually trying to do? Well, it's not just about going more often. It's really a three-part goal. We want to increase frequency, sure, but we also need to improve the stool's consistency and, this is critical, manage the pain and bloating that are often the worst part for the patient.
We approach this with a really logical step-by-step ladder. We always start with the foundation, lifestyle and diet changes, things like fiber, fluids, and maybe a trial of a low FODMAP diet. If that's not enough, we move up to gentle osmotic laxatives. And for those who still need more help, we've got fantastic first-line prescription meds called secretagogues, and even some second-line options after that.
Okay, lean in for this one. This table is pure gold. Whether you're on the wards or studying for an exam, it breaks down those main secretagogues. You've got luperoprostone, which is a chloride channel activator, and then linaclotide and plecanatide, which are GCC agonists. The bottom line is they all pull more fluid into the intestine, but knowing their specific mechanisms and side effects is absolutely key.
All right, let's flip the script. We've talked about getting things moving. Now, what do you do when the system is just way too active?
This is the challenge of managing IBS-D.
And here, too, our goal is all about improving quality of life. We want to cut down on the frequency and, maybe most importantly, that awful sense of urgency that can completely run a patient's life. We also want to improve the stool form, get it higher up the Bristol scale, and get that cramping and pain under control.
The approach here also kicks off with diet. That low FODMAP trial is still a great first step, but from there, our pharmacologic toolbox looks totally different. Loperamide is great for on-demand episodic control. Then you've got cool targeted therapies like rifaximin, an antibiotic that can kind of reset the gut bacteria, and other specific modulators like aluxitiline and, for very select cases, allosetron.
And you can see here the mechanisms are really all over the map. Rifaximin is an antibiotic, aluxitiline is an opioid modulator, allosetron is a serotonin antagonist. They're all very different. That's why knowing their specific warnings is so critical, like the pancreatitis risk with aluxitiline or the rare but serious risk of ischemic colitis with allosetron. Okay, let's take a final step back and zoom all the way out. We've talked about the what and the how of managing the bowel symptoms. Now let's talk about the why. Why do these patients feel so much pain and discomfort in the first place?
A huge piece of the puzzle for so many of these patients is something called visceral hypersensitivity. It's a fancy way of saying their gut is just extra sensitive. The nerves are on high alert. And this is where low-dose neuromodulators like tricyclic antidepressants or SSRIs can be game changers. We're not using them for depression. We're using them at low doses for their powerful effect on calming down those overactive nerve signals in the gut.
So, if you remember one thing from all of this, let it be this. IBS is not just a bowel problem. It's a disorder of the brain-gut interaction. The communication superhighway between the central nervous system and the gut's own nervous system has gotten scrambled. Understanding that reframes everything.
And that leaves us with this final thought. When we explain this brain-gut connection to our patients, it's incredibly validating for them. It helps them understand it's not all in their head, but that their head and their gut are truly biologically connected. This understanding lets us move beyond just writing prescriptions and instead partner with them on a plan that empowers them to really get control back over their lives.